Am I audible to everyone?
Yes.
Yeah.
Good afternoon, everybody. I'm sorry for the delay. Actually, I welcome you all to the today's topic, that is evaluation of urinary tract by MR imaging and CT urography and radionuclide imaging. The guest speaker for our session today is Dr. P. Sridhar. I welcome you, sir.
Thank you.
A small brief introduction regarding your achievements. He has done his MBBS and internship from Visakhapatnam, then MS General Surgery from Jipmer Pondicherry, M.Ch Urology from Guntur Medical College, Guntur. He has got various experiences as working as a senior resident in General Surgery in Jipmer, following which he worked as consultant urologist in Indus, where I worked for him for a short time. Worked as a consultant urologist at Queen's NRI Hospital. Later, he joined into AINU Visakhapatnam and currently holding the same position in AINU Visakhapatnam. He has got a lot of academic achievements like Dr. Alasingari Medal in Physiology, Dr. Vallabrao Prize in SPM, Gold Medal in ENT, Dr. B. Ramamurthy Memorial Prize in Pediatrics, Lieutenant Colonel F.J. Anderson Medal for the Most Distinguished Graduate in MBBS, Dr. C. Sita Devi and Dr. C.R.R.M. Reddy Endowment Award by Andhra Pradesh Academy of Sciences for securing the highest marks in MBBS year 2009, Professor B.N. Balakrishna Rao Prize in MS General Surgery for securing highest marks in internal assessment for the year 2013, and Urological Society of India International Travel Fellowship to Nepal in 2016. Lot of good achievements, sir, and he is also a member of a lot of other societies and lot of publications and papers in national and international levels. I welcome you, sir, to today's platform.
Thank you.
Today's speakers are Dr. K.L. Srujana, working as a radiologist in Visakhapatnam branch VDC, and Dr. Santosh Nandigam, sir, working as a consultant nuclear medicine expert at VDC Vizag. I hand over the platform to you both for continuing the topic today.
Shall I start?
Yes, definitely, ma'am.
Yes, ma'am.
Am I visible?
Yeah.
Today I'll be talking about the role of CT urography in the evaluation of the urinary tract. CT urography is also known as CT IVP. It has largely replaced the traditional IVU in the evaluation of the genitourinary tract. It gives both anatomical and partly functional information, however, with a little higher dose of radiation. Indications are like hematuria, urothelial masses, obstructive uropathy, urothelial cancer surveillance, strictures, congenital collecting system abnormalities, and it has very high sensitivity and specificity in identifying ureteric and bladder caliculi. Its main purpose is to illustrate the collecting systems, the ureters and urinary bladder with IV contrast in a single acquisition compared to multiple and more dynamic traditional IVU. Visualization of other structures in the abdomen is also better with CTU than traditional IVU. The following imaging technique is popularly used nowadays. It is the unenhanced scan, nephrographic, and the pylographic phases. After an initial unenhanced acquisition, nephrographic phase images are required approximately 90 to 100 seconds after the administration of non-ionic contrast agent. The nephrographic phase has the highest sensitivity in detection of renal masses, and correlation with unenhanced images is required to show unequivocal enhancement. Pylographic phase images are required approximately 5 to 15 minutes after administration of contrast to evaluate the urothelium from kidneys to urinary bladder. I'm straightly coming to the cases. This is a case of bilateral hydronephrosis. Here, these are the maximum intensity coronal images of CT urogram, nicely depicting the pelvic, grossly dilated pelvic calyceal system on the right, with no obvious opacification of the ureter, which is consistent with pelvic ureteric junction obstruction on the right side. On the left side also, we see there is mild hydronephrosis with narrowing at pelvic-ureteric junction. However, there is contrast opacification of the ureter. So it might be only a mildly partial stricture on the right side. To know how much of obstruction is there, we have to follow the study with an IVP or nuclear medicine studies. This is another case of a retrocaval ureter. Here we see that there is moderately dilated pelvic calyceal system and the proximal ureter with abrupt turning of the proximal ureter medially at the level of L3 body level. So here the obstruction is due to retrocaval nature of the ureter. These are the maximum intensity projection and these are the volume rendered images. This is another case. These are the hylographic image showing the contrast within the pelvic calyceal system. On the left side, there is moderate degree dilatation of the entire pelvic calyceal system and the ureter up to the vesicureteric junction. However, it is not opacified, though it is a pylographic phase. So it is an obstructed system. It is a case of congenital megaureter. These are the coronal. This is another case, coronal MIP image. These are the coronal MIP images showing a calculus at the junction of proximal and mid ureter with mild hydronephrosis. CT urography is very helpful in detecting the size of the calculus. So CT urography findings predict the likelihood of stone passage in that larger stones are less likely to pass spontaneously. Spontaneous passage rates for ureteric caliculi are 76% for 2 to 4 mm caliculi, 60% for 5 to 7 mm and 48% for 7 to 9 mm caliculi and less than 25% for stones larger than 9 mm. Coming to the role of CT urography in the assessment of urothelial tumors or renal malignancies. Here, these are the plain or non-contrast images through the kidney shows an abnormal altered attenuating lesion involving the anterior portion of the left kidney, which is partly exophytic, which on nephrographic phase is showing heterogeneous enhancement with central non-enhancing area and bulge in the contour. It was a case of renal malignancy. In renal malignancy, we can also assess for regional and distant metastasis of the renal malignancy as well as the extent of involvement of adjacent vascular structures like the renal vein or the artery. This is another case. These are the pylographic image. Here on the left side, we see that the left kidney is contracted compared to right and there is moderate degree dilatation of the pelvic calyceal system and the entire ureter. Here in the mid ureter, we find some mildly enhancing mass involving the ureter. And as we go lower down at the level of the urinary bladder, we find another endophytic projecting enhancing mass, which is also involving the vesicureteric junction. So it is a case of multifocal transitional cell carcinoma. So in the assessment of urothelial cancers, we can also look for multifocality of the disease in CT urography. Coming to the advantages of CT urography, the 3D reformations with coronal and sagittal maximum intensity projections of the kidneys and urinary tract, urinary collecting systems, it's very helpful, and unenhanced CT has very good sensitivity in detection of urinary tract caliculi. We need not give contrast for just assessing the caliculi and their obstructions, and for evaluation of extrarenal pathologies. CT urography outperforms the ultrasound, excretory urography, and radiography in the evaluation of renal parenchymal masses, pelvic calyceal, and ureteric transitional cell carcinomas. It is the first line of investigation in the evaluation of hematuria when the risk of disease outweighs the risk of radiation exposure, as in the case of patients at high risk of urological malignancies. its potential pitfalls and how they can be avoided. Radiation doses in CT urography can be reduced by limiting the number of imaging phases through the use of dual energy CT or split bolus technique. Dual energy CT, it obviates the need of an unenhanced phase of imaging because a virtual unenhanced CT can be post-processed from a contrast-enhanced study. This CT technique has shown great promise for differentiating solid renal masses from hyperdense renal cysts and for determining the composition of the renal caliculi, which may help guide treatment. Radiation doses can also be reduced by use of split bolus technique. Here, the unenhanced acquisition is followed by IV administration of 30 to 50 ml of contrast, followed by a second bolus of 80 to 100 ml at 8 to 10 minute delay, during which the acquisition is performed. So we can reduce the number of phases, that is the direct nephrographic phase can be reduced. Thus, in a single nephrophilographic phase, the renal parenchyma as well as the collecting system can be assessed. This is the CT nephropylogram of the normal patient using split bolus technique. Here we see that there is enhancement of the renal parenchyma and excretion of the contrast into the pelvic axial system. Detection of urothelial tumors is widely believed to rely on optimal distinction and opacification of the ureters and the collecting systems. So complete bilateral distension of ureters is very difficult to achieve because of peristaltic contractions. Oral hydration with 1 liter of water to 20 to 60 minutes before the CT urography can improve the delineation of ureters by promoting diuresis. Prone imaging also helps ureteric distension, but prone imaging is quite uncomfortable, and imaging in prone position is basically used to discriminate the free intravesical stones and those impacted at the uretrovesical junction. Compression and diuretics can also be used for optimizing ureteric imaging. Compression can increase the proximal ureteric distension and can be released for imaging of distal ureters. However, on using compression techniques, we require more additional imaging sequences. So, indirectly, we increase the amount of radiation exposure. Administration of a low-dose diuretic 1 minute before CT urography also improves mid and distal ureteric opacification and distension. This technique decreases the attenuation in the ureters and reduces the time delay for pylographic imaging, but is not suitable for all patients. The disadvantage of CT urography compared to IVP is encountered in imaging of patients with asymmetric excretion, as I have shown in the case of multifocal TCC and obstructive megaureter, particularly those with unilateral obstruction. In these patients, the lack of sequential imaging with CT can result in suboptimal opacification and pylographic phase on the obstructed side. Coming to the dosage values, plain CT KUB is around 7.7 millisieverts and 3-phase CT is around 23.1 millisieverts. Compare it to IVP, which is around 3 to 3.5 millisieverts. CT urography is the most sensitive and specific test for the diagnosis of urinary tract caliculi and detecting and characterizing renal masses. Thank you. Over to you, Dr. Santosh.
Am I audible?
Yes.
Am I audible?
Yes, sir.
Yes, yes.
So I'm going to speak. I'm going to speak today on urinary tract imaging by radionuclide urinogram. So this urinogram is a non-invasive test that can evaluate renal function and urine transit in a single procedure. The basic principle used is based on high endogenous rate of urine flow stimulated by the administration of Lasix or furosemide. And the interpretation is based on the renal function and as well as urine drainage of the radiopharmaceutical from the collecting system. The common radiopharmaceuticals which we use in a radionuclide renogram are technetium-99 DTPA, which is based on glomerular filtration, and technetium-99 MAG3, technetium-99 EC. These two based on tubular secretion. MAG3 is mercaptoacetyl triglycine and EC ethylene dicysteine. These both are tubular secreting agents. So how we do a renogram? First, we have to prepare the patient. Generally, hydration is most important, and if bladder catheterization is required, then we do a bladder catheterization. IV cannulation we generally do, or direct injection can be done if the technologist is very confident. Sedation based on the irritable patient. If the patient is cooperative, then we no need for sedation. Then procedure is generally the selecting the radiopharmaceutical, whether DTP or EC, and the dose will be like 1 to 5 millicurie. We generally give as a bolus injection, and after this injection, we wait for some time, or like depending upon the protocol, we inject a diuretic, the Lasix, the dose and timing may be like I'll discuss in the later part. The total time of the scan generally is around 20 to 40 minutes. We generally take pre-void, post-void, delayed images. Generally, the acquisition will be posterior acquisition. If at all, like the kidney positioning is like already known, it is located in a different position other than the renal fossa. Generally, we acquire anterior acquisition also. The supine position is mostly preferred. And after the procedure completion, we do the processing. Generally, we take a region of interest, whether it will be whole kidney or cortical, and we draw a background and aortic, and we see the time activity curve, and then we interpret the scan. So during interpretation, first thing we generally see is the perfusion phase, which we call as the angiogram phase. Once the radionuclide is injected as a bolus, it transits through the aorta, and then it passes through the kidneys. So generally, we visually interpret the aortas as well as the kidneys. We generally don't quantify, except in the case of transplant kidneys, where we require the perfusion phase and quantification as a Hilson index. And after this perfusion, generally the tracer gets either filtered or secreted. So generally we see the first 2 to 3 minutes will be the cortical phase, and then from the cortex to the transit to the pelvic alical system. So first 2 minutes is the main cortical function we assess. So the visual interpretation is most important. We visually interpret the size, shape, and position of the kidneys and the relative cortical uptake in both the kidneys. The parenchymal transit from the cortex to the pelvic alical system. What about the pelvic alical system, whether it is a normal or it is a dilated? What about the ureter, if it is visualized as a normal or just a faint as a dilated? And if there is a narrowing site, whether it is in the upper PUJ or at the VUJ junction, we can assess if it is visible. And is there any reflex? Generally, this is a DTPS. This is a indirect radionuclide renogram. Generally, reflex is not clearly visualized. Then bladder activity has to be assessed, whether it is full or like it is if it is a VUJ, it is partially filled. About the background activity, this is the visual interpretation. And regarding the quantitative parameters, we generally assess the differential renal function, glomerular filtration rate, T-peak, T-half, output extraction efficiency, and normalized residual activity. This is the basic about renogram. So now coming to the clinical perspective, in which conditions generally the clinician faces a difficulty, like when to prescribe a radionuclide renogram, whether in which clinical condition, like just like hydronephrosis or renal stones or renal mass, chronic kidney disease, ectopic kidneys or transplant kidneys, horseshoe kidneys, multicystic kidney disease. So till now, actually, with all the experience, actually, radionuclide renogram can be prescribed in each and every condition. There are no contraindications except pregnancy. So one more doubt for the clinician is whether which radiopharmaceutical has to be used, and Lasix has to be used or not, whether at what time Lasix has to be given, depending upon this radionuclide renogram interpretation, what the treatment has to done, and what is the outcome of the patient. These are all can be clarified with radionuclide renogram. So we'll first see which radiopharmaceutical is the best to do a renogram. So generally we use both glomerular filtering agents as well as tubular secreting agents. The main important and most advantageous among these are the tubular filtering agents, tubular secreting agents. So the available are MAG3 and EC. MAG3 and EC are tubular excretion agents. Almost 50% is excreted. The high first pass extraction of these two agents is high, and within 30 minutes, almost 72% of the dose is excreted from the kidneys to the bladder. So the radiation exposure also is very less with these tubular secreting agents. When coming to DTPA, it's a pure glomerular filtering agent. 20% is only glomerular filtered, and remaining activity again goes through the vessels, and the extraction efficiency is almost 20% only. So the complete excretion of this DTPA really takes almost more than 5 hours. So when compared to these radiopharmaceuticals, generally the prescribed and preferred pharmaceutical is the EC, because EC is little bit 10% to 20% more high first pass extraction than MAG3. These are the differences what the literature has documented. In tubular secreting agents, the EC is most preferred. These can be preferred when glomerular filtration is like relatively less, or some glomerulopathies and acute tubular necrosis. And when in neonates and infants where this renal maturity is not that much, so EC scan can be preferred. And in early postoperative assessment where the tubular functions are early than the glomerular function, so EC can be relatively used. And in the same, this slide is both the radiopharmaceuticals are utilized in the same patient to demonstrate which is better. So when we see the EC scan, after injecting, it almost transits through the kidney, and within 60 minutes, most of the radiopharmaceutical comes to the pelvic callus system, and by the end of 13 minutes, half of the tracer is cleared, and by the end of 25 minutes, almost 80 to 90% of the tracer is cleared. Whereas in DTPA, it is slowly clear. It is slowly cleared. By the end of the study, we can see the tracer. Still, we can see the tracer in the pelvic callus system. So the curves are also in the down. We can see the curves in the DTPA. The curve is like slowly down sloping, whereas in the EC scan, it is abrupt. So like in low grade to intermediate obstruction, generally if EC is preferred, the results are very accurate. So when the drainage is not normal, whether the pelvic callus system is obstructed, the drainage is obstructed. So once we see the baseline image, at what time the diuretic can be used? What is diuretic? How it acts on the renal system? Everyone knows. Generally, we use a furosemide, which it increases the urine flow rate. The diuretic dose is generally we use 1 milligram per kg body weight. Generally, the maximum is 40. If the body surface area or body weight is high, generally if the creatinine is high, generally we increase the dose maximum up to 80 milligrams. The diuretic renal action begins within 1 to 2 minutes, and the maximum effort comes at around 10 to 15 minutes. So the timing of the injection, there is a lot of literature and lot of research went in the past. O'Reilly and colleagues have introduced F20 protocol. So first, they injected a radionuclide, and they have waited for 20 minutes to see the baseline scan, and they injected a radionuclide. They injected a diuretic. So these are the curve patterns they have documented. This is the first type. They have documented four types of curves. Type 1 is a normal curve, which is like there is no obstruction in the drainage. This is a type 2 curve where the one kidney is completely normal, and another kidney there is a pooling in the pelvic callus system, which is showing an upslope curve. This is a complete obstruction. This is a type 3 curve where both the kidneys are intermediate obstructed kidneys, but after giving the Lasix, there is an abrupt fall of the abrupt clearance of the tracer. There is an abrupt fall of the curves. These are high concave shaped curves. These are hypertonic curves, and these are non-obstructed. And these are type 3B curves, equivocal curves. Like even after Lasix injection, there is a slow clearance. There is an intermediate obstruction. So following this F20 protocol is little bit lengthy procedure and more radiation exposure, because the patient has to hold his bladder and most of the radioactivity will be stored in the bladder for a much longer time. So more radiation exposure, and if the patient is non-cooperative, then the study has to be stopped in between. So these parameters will be not accurate. So to compensate these, many other protocols were introduced by English et al. They have introduced F-15 because the maximum effect of Lasix comes at around 10 to 15 minutes. So they have introduced 15 minutes. So when the maximum effect of diuretic comes into action, immediately they inject a radionuclide. So with the help of the forced diuresis, they have assessed the kidney function as well as drainage. But because of this 15 maximum effect, sometimes if there is an obstructed kidney, so there will be like reduced estimation of the cortical function. So this F-15 is not regularly accepted. So one more technique was introduced by Wang and colleagues, F0 protocol. F0 is at the same time this radionuclide as well as the Lasix were injected. So by 2 to 3 minutes, the main action of Lasix comes into action. So by that time, the normal radiopharmaceutical transit from cortex to pelvic ulcer system occurs, and with the help of the forced diuresis, this tracer will get excreted. So F-15 and F0, they have a disadvantages because they lack baseline renal function, whether it is physiologically like obstructed or not. These kind of disadvantages are seen. So one more method has been introduced to assess the basal renal function, F10 protocol. Initially radionuclide is injected, and for 10 minutes the basal renal function is estimated, whether it is normally clearing or not. If there is any stasis or any obstruction, then diuretic is injected, and after that 20 minutes the scan is acquired. So the basic renal function estimation can be done, and diuretic renogram can also be done. So it is easily performed. The 25 minutes is not a very easy ample time for the patient to hold his bladder. So, and better patient compliance is used to occur, and this F10 protocol is widely accepted. Many guidelines are also nowadays advise F10 protocols. The same curve patterns are the same, just like F20 protocols. You can see this type 1 is normal, which is clearing normal. Type 2 is completely obstructed. Type 3 are hypotonic curves. Type 3 is equivocal curve. So the curve patterns are more or less the same as F20 protocols. So in almost all the centers, F10 protocol is accepted. So after the Lasix, if there is still stasis in the pelvic ulcer system, first of all, we have to rule out whether because the patient position is in supine position, there is no gravity assisted drainage. So if there is any like ballooning of the pelvis or like dilated pelvis, if there is any reservoir effect, the stasis will be there. So generally, even after Lasix, if there is a stasis of the tracer in the pelvic ulcer system, we suggest the patient to get up and to walk for some time and get micturated, so that most of the tracer will, if there is no mechanical obstruction or like anatomical obstruction, generally the tracer comes down into the bladder. So the obstruction can be ruled out. This is most important, gravity assisted drainage. So in case of low grade 2, if there is a significant obstruction, obviously it will be very evident. If it is a normal obstruction, if there is no obstruction, if it is a normal draining, obviously it is very evident. But in case of low to intermediate obstruction, or like in post pyeloplasty, there will be still residual obstruction. The decision making is very important, whether to see only obstructive uropathy is there or there is any kind of obstructive nephropathy. Because of the high back pressure, the tubular function will be like slowly getting damaged. If it is an acute obstruction, the more amount of the damage to the kidneys. If it is a chronic obstruction, the little slow damage. So based on these renograms, we need to quantify whether it is only obstructive uropathy or obstructive nephropathy. So generally, to differentiate between an obstructed uropathy or obstructed nephropathy, generally we decide whether to draw a whole kidney ROI, or to differentiate between the cortex and the pelvic ulcer system. So drawing two curves sometimes may be beneficial to differentiate. There is a cortical damage, and to differentiate the pelvic ulcer system obstruction. Whole kidney ROI, if it is drawn, sometimes cannot give a proper information on the kidney function as well as drainage. So if we draw a cortical ROI, if the cortex curve If the cortex curve comes down, there is no, the parenchymal transit of the tracer is relatively good. So that means the nephrons are functioning properly. There is no cortical nephropathy. And this is the PCS curve. There is a pooling of the tracer in the pelvic calcium system, and it is showing it is upsloping curve. So we can clearly differentiate whether it is a pure obstructive uropathy or associated with obstructive nephropathy. This is the quantitative parameter. This is the quantitative parameters what we estimate in the renogram curve. This is the GFR, ERPF, kidney area size, kidney depth, whether both the kidneys are in the same depth or not, the time to peak and peak to half peak. These are the main important parameters what we routinely take it into consideration. These are the two parameters, output extraction efficiency and normalized residual activity. Output extraction efficiency is the amount of tracer extracted by the kidneys from the plasma, and it is cleared in the considered time interval. So if the amount of tracer, the maximum amount of tracer, if it gets excreted, then the kidney function, kidney parenchymal function will be better, and the parenchymal transit is also much better. So the output extraction efficiency estimation is very important in low to intermediate grades of urinary tract obstruction. And normalized residual activity in the pelvic calcium system at the end of the renogram or even after 1 hour, if you see that, if you can see a delayed image, if their counts are still persisting, and we compare with 1 to 2 minute or 2 to 3 minute counts, if the delayed counts are higher than the 1 to 2 minute, then obviously it's an obstructed drainage system. If the delayed images show reduced counts, then it is how much we can quantify how much is the difference. So depending upon this quantification, we can say whether it is a low grade or it is an intermediate grade obstruction. The same what we try to depict is a 3 minute. At 3 minute, we try to quantify how much are the counts. And in a pre-void image, at the end of the study, we take a pre-void image and we take the full pelvic calcium system counts, and we ask the patient to get up and void, and we take the counts. And even after 1 hour, we take the counts. So in case of delayed image, if the counts are high, then it is a obstructed kidney. Sometimes if there is a like reservoir effect or like dilated pelvis, generally these counts will come lesser than the pre-void or like in the flow dynamic images. So this quantification is really important to decide for and to interpret in the report, or like to suggest a clinician whether to intervene at that point of time, or they can observe for some time and they can do a follow-up. So these important points regarding this renogram, obstruction is based on the renogram, can be categorized as low, intermediate, and high grade based on the renogram. Other parameters need to be considered like dilated pelvis, reservoir effect, and quantitative parameters. No single parameter can serve to distinguish obstructed and non-obstructed. We have to consider all the factors, and we have to decide whether that a kidney system is obstructed or non-obstructed or relatively like low grade or intermediate. All the relevant parameters need to be considered and integrated to reach the conclusion. We cannot say that if it is a T half is like prolonged, we cannot based on the T half that it is a obstructed system. We need to take into consideration like post-void images as well as delayed images, this residual activity, everything we need to take into consideration, and then we have to consider this system as an obstructed system. Nowadays, actually, this machine learning process has been coming into existence. We have RENEX systems and everything. So based on these curves, there will be some errors. So we are trying this machine, based on machine learning, we are trying to quantify whether some kind of obstructed curves can be considered as a non-obstructed curve, or non-obstructed curves can be depicted as obstructed because the ROI drawn on the kidney, if it is the ROI is halfly placed on and the rest of the dilated pelvis is excluded, then that ROI, that curve will be depicted as a non-obstructed, but in fact it is an obstructed system. So nowadays new technology has been coming based on this machine learning. So any nuclear medicine physician or a clinician has to consider entire parameters of the renogram and it is not suggested that based on these curves, one has to consider as an obstructed or non-obstructed. So the drawbacks of the renogram, as we know that anatomical characterization of the renal lesions cannot be done, or any renal or ureteric obstruction due to extensive lesions or extensive vessel crossing, this cannot be done. It has to be done by a radiological imaging. Coming to radiation dosimetry, the radiation dosimetry is very less. The target organ is a bladder wall. We can see with the DTPA, it is almost 0.007, and MAC3 it is a little bit high because the excretion is higher. So immediately, but the total procedure is very limited, almost around 20 minutes. Immediately after voiding, the entire radionuclide will get excreted. So the radiation exposure is very, very less. Now coming to the future perspectives, what is going in the nuclear medicine? So till now, actually, we don't have any anatomical characterization or anatomical correlation. It is only physiological correlation. Nowadays, actually, PET has become a main modality in the nuclear medicine. So these dynamic images are coming into trial basis. So new radiopharmaceuticals like 68 gallium EDTA and 18F fluorosorbital, these are being tried to estimate PET-based renograms. The advantages are superior pharmacokinetics and low protein bond, superior resolution, absolute quantification, and we have a CT for anatomical co-registration, and the radiopharmaceutical dose also we can reduce. For example, if we give 5 millicurie of DTPA, we can give around 0.5 to 1 millicurie of fluorosorbital. With this PET renogram, we can estimate GFR, and the time activity curves generally generated exclusively from cortex and collecting system. We can differentiate obstructive nephropathy as well as obstructive uropathy. This is a study published in European Journal of Nuclear Medicine. This fluoride FDS was injected, and in almost this one, initially they have taken a CT, they have injected here, and we can see within 2 minutes, almost entire cortex has taken up the tracer, and by the end of 7 minutes, almost it is getting excreted into the pelvic ulcer system, and by the end of 10 minutes to 15 minutes, it almost getting excreted. So we can see the anatomical characterization as well as the excretion. This is the time activity curves which they have predicted in that study, and we can draw there are 3 regions, whether it is a cortex, this is the intercalcium system, and this is the collecting system. So they have depicted the entire drainage into the drainage system. So this additional advantage for this PET is an anatomical characterization. Till now I have spoken about indirect radionuclide radiogram, where we can depict only upper urinary tract imaging. If we have any reflex or anything causing secondary hydronephrosis or like obstruction, we need to do a radionuclide radiogram. Obviously, MCOG is regularly done. Sometimes radionuclide cystogram can be done, but only thing is the grading is slightly different from this radiography. Only 3 grades are given. This is just for a completion I have kept. So the final conclusion is the radionuclide radiogram provides estimation of perfusion, differential renal function, drainage pattern. MAC3 and EC is better for estimation of renal function and drainage when compared to DTPA. DTPA, being a glomerular filtering agent, provides information on GFR. For intermediate obstructive drainage, quantitative parameters estimation gives better analysis. Thank you.
That was a wonderful session with both Dr. Srujana ma'am and Dr. Santosh. Now the forum is open for any questions by Dr. Sridhar. Please, sir.
Yeah, I think we should congratulate both the speakers. They have briefly and given a very much useful information as well. So, like for a urologist, like when we have a patient who presents with us with obstructive features, obstructive uropathy. So actually, CT and radionuclide both are usually they are complementary. Like in some patients, we may need to use both the modalities. But like Madam told, CT we prefer when we need a better anatomic information, because function information is like better with radionuclide. But most of the patients we like to see how is the anatomy of the renal parenchyma, how is the anatomy of the PCS and ureter. So if we are suspecting a PUJ obstruction, we can straight away go and do a with ultrasound report of a hydronephrotic kidney in a child. We can straight away skip CT and do a radionuclide scan. Because in child usually we don't do a CT because one thing it is we unnecessary exposure to radiation and there is a risk of contrast induction as well. So in children usually when the diagnosis is mostly clear, like a patient's child coming with antenatal hydronephrosis, we are suspecting PUJ obstruction. So anyway, for PUJ obstruction, we need to operate depending on the renal APD, fluid diameter. So in children, usually we suggest them to go for a nuclear scan directly because we need functional information and we like to prognosticate the case. Like for post-op follow-up also, the radionuclide scan will give much better information depending on the curve, whether it's type 2 obstructed curve or type 3A, type 3B or 4. So what we do is usually type 2 curve, definitely we need to go ahead with surgery. Type 3A, where there is immediate downfall of graph with diuretic. So in those children, we can wait and follow them up. Type 3B and type 4 also, because the obstruction is much more severe. Usually, we consider doing a surgical management. So, in my opinion, usually in children, we go ahead with a nuclear scan after a ultrasound report of a hydronephrotic kidney. But CT urography, like Madam told, it is useful in cases where we need better anatomical information, like we are suspecting a um, uh, stricture at the level of ureter. So where exactly is the level of stricture? That will be better seen on a CT. Because anyway, radionuclide scan will show that there is obstruction, but the exact location of obstruction so that we can plan the surgery. So that information is much better seen on a CT. Because suppose there is a proximal ureteric obstruction or stricture, we usually do something called ureterostomy. We just cut the stricture spot and join them. But if the stricture is at the distal level near the bladder, we cannot do a ureteric anastomosis. We usually do a flap with the bladder, ovary flap, or a reimplant into the bladder. So the state of stricture it changes the surgical plan also. So in those patients, definitely CT urography is much better. And also sometimes there will be some I'm told renal masses or bladder masses. They will be much better picked up on CT. So CT urogram in such patients also useful. And also the availability, because CT nowadays is available in most of the centers. So like radionuclide is only available in major cities. So that also plays a major factor, like economic and demographic parameters also. They also influence our decision management, like whether we should send for CT or a nuclear scan. But definitely both of them are on par with each other. Depending on all these factors, we decide what to do for the patient. So that is my inputs after hearing to the talk. So we used to do IVP previously, but CT urography, that's what is being done nowadays. Because IVP is outdated, we don't see the anatomical information with that. And because we're getting much more information with CT, which is also easily available, like centers which do IVP, most of them will do CT urography as well. So that is the go-to investigation mode.
Nowadays, CT urography is sent for also urethric cavity, right? What is the
Calculate.
mean? Like, what you
No,
want?
only useful, only useful information we get with CT urography in renal calculus is regarding the function of the kidney. So if there is acute obstruction in the ureter, there will be delayed contrast uptake and delayed excretion. So that indicates that the obstruction is much more severe and we need to intervene as early as possible. But usually, if patient presents with us with the pain and we are suspecting a stone on ultrasound, 90% of the time we do only plain CT. But if the stone size is large and patient is having severe pain or his creatinine is elevated or he is having fever or UTI features, so in those cases, we think that renal function also may be doubtful. So in those patients, we suggest a CT urography because we need to assess the function also. But otherwise, 90% of the time for stones, plain CT should be good enough. And stones, usually radionuclide scan we do rarely unless we are suspecting a concomitant PUJ obstruction. Because some patients, stones may not be primary. They may have secondary stones due to a PUJ obstruction. So because of the stasis of the urine in the kidney, they may be forming secondary stone. So what we do is we get a plain CT. The pelvis is very much dilated, but the stone is not at the PUJ. It is in the renal calyces And depending on the stone HU and depending on the stone shape, because there are multiple round stones, we usually suspect a PUJ obstruction is the main cause and stones are only secondary. But if there is stone at PUJ and there is a huge hydronephrosis, then we straight ahead do a CT or CT urography and proceed. But if you are suspecting PUJ obstruction concomitantly, then definitely radionuclide scan is useful because it will also prognosticate. We can tell the patient that he may need even surgical correction of the PUJ even after clearing the stone. So that is the primary pathology rather than the stoneus. And like you told, in urothelial tumors, CT urography definitely gives a lot of information because we can see the bladder mass, we can see ureteric or renal calcium masses as filling defects. So in those cases also, CT urography is very much useful.
And post-surgical ureteric damages and
Yes,
all
yes,
of the CT urography plays a major role.
yes, yes, definitely. Because we get a lot of patients post gynec surgeries or post any pelvic surgeries like APR, anterior section. Any pelvic surgery, there is high risk of ureteric damage and stricture. So CT urography definitely tells the level of stricture. Like I told, if it is a distal part, the whole surgical plan will be changed. So in those patients, CT urography is definitely a must.
Yeah, it was a nice discussion by all the doctors. If any more questions are there, if no further questions, I thank Dr. Sridhar, Dr. Srujana, and Dr. Santosh for nice presentations and the discussion. Thank you all. Thank you.
Thank you,
I
Dr.
close the